Type 2 Diabetes in the Pediatric Population by Michelle Dzizik, Brooke Johnson, Colleen Murphy, and Kate Donnelly. The objectives are: the student will be able to define diabetes mellitus and discuss the differences between type 1 and type 2. Students will be able to determine if medications are needed and which medications can be used. Students will be able to identify ways to reduce caloric intake in children and adolescents with type 2 diabetes, and the student will be able to identify ways to incorporate exercise into a daily routine for a child with type 2 diabetes. Type 2 diabetes is increasing prevalence. In 2013, the American Academy of Pediatrics released the first clinical guidelines for treating type 2 diabetes mellitus in pediatric population. Currently, in the United States, approximately 1 in 3 new cases of diabetes mellitus diagnosed in patients younger than 18 is type 2, with a disproportionate representation in ethnic minorities, especially among adolescents. This trend is not limited to the United States, but is occurring internationally as well. Some risk factors for getting type 2 diabetes: being overweight, a family history of diabetes, being of a female gender, in specific ethnic groups such as American Indian, African American, Asian, and Hispanic. Most children with type 2 diabetes are diagnosed at the start of puberty. Some causes of obesity are unhealthy eating patterns, lack of physical activity, an inherited tendency, rarely a hormonal problem or other medical condition. The risk of type 2 diabetes in children appears to be associated with excess abdominal weight. This obesity pattern increases the chance of insulin resistance and the risk of type 2 diabetes. According to the American Academy of Pediatrics, children and adolescents are defined as patients less than or equal to 10 and less than or equal to age 18. Diabetes is a group of diseases marked by high levels of blood glucose resulting from defects in insulin production, insulin action, or both. Diabetes can lead to serious complications and premature death, but people with diabetes can take steps to control the disease and lower the risk of complications. There are 2 types. Type 1, previously called insulin-dependent or juvenile onset, accounts for approximately 5% of all diagnosed causes of diabetes in adults, and type 2, previously called non-insulin dependent or adult onset, accounts for 90 to 95% of all diagnosed causes of diabetes in adults. Type 2 diabetes is increasingly being diagnosed in children and adolescents. Type 2 diabetes is due to 3 possible defects: insulin resistance in muscle and adipose tissue, beta cell dysfunction, and excessive hepatic glucose production. Research has shown that by the time type 2 diabetes mellitus is diagnosed, at least 50% of beta cell function has been lost. At the same time, the liver produces more glucose than the body can use, causing a further increase in plasma glucose levels. Insulin is then needed to shut off liver glucose production. With less circulation, insulin, and marked insulin resistance, the liver continues to make glucose in an unrestrained manner. The symptoms of type 2 diabetes are increased hunger or thirst, unexplained weight loss, frequent urination, fatigue, blurred vision, heavy breathing, dry mouth, itchy skin, and numbness or tingling in the hands and feet. Approximately 215,000 Americans younger than age 20 have diabetes. Although most cases of diabetes are type 1, as obesity rates soar, type 2 diabetes, a disease that used to be seen primarily in adults over age 45, is becoming much more common. The American Academy of Pediatrics has stated specific guidelines when dealing with type 2 diabetes mellitus. For once, ensure that the insulin therapy is initiated for children and adolescents with type 2 diabetes who are ketotic or in diabetes ketoacidosis, and in which the distinction between type 1 and type 2 is unclear. Second, initiate a lifestyle modification program, including nutrition and physical activity, and start metformin as a first-line therapy for children and adolescents at the time of diagnosis. Third, monitor the HbA1c concentrations every 3 months and intensify treatments if the treatment goals for finger stick blood glucose and the concentrations for hemoglobin A1c concentrations are not being met. Fourth, advise patients to monitor finger stick blood glucose concentrations in patients who are taking insulin or other medications with risk of hypoglycemia, are initiating or changing the diabetes treatment regimen, have not met treatment goals, or have intercurrent illnesses. Fifth, incorporate the Academy of Nutrition and Diabetics Pediatric Weight Management Evidence-Based Nutrition Practice Guidelines in their dietary nutrition counseling. And sixth, encourage children and adolescents with type 2 diabetes to engage in moderate to vigorous exercise for at least 60 minutes daily and to limit non-academic screen time to less than 2 hours a day.
Sorry, how do I click to the next thing? According to the Academy of Nutrition and Dietetics Guidelines, incorporating lifestyle changes such as including a diet of 900 to 1200 calories per day is associated with both long-term and short-term improvements in weight status and body consumption in children ages 6 to 12. These calorie recommendations are to be incorporated with lifestyle changes that include exercise and possibly medication as well. Research has also shown that calorie restrictions in adolescents ages 13 to 18 years of age should consume no less than 1200 calories per day. Also was shown to also result in improved weight status and body consumption. Specific interventions are intended to be conducted on a short-term basis, usually about 10 weeks, and to be conducted under the supervision of a multidisciplinary team that specializes in pediatric obesity. The American Academy of Pediatrics recommends that regardless of what meal plan is prescribed for the child or adolescent with type 2 diabetes, some degree of nutrition education must be provided to help maximize adherence to the program and to achieve maximum results. The education provided should encourage patients to follow healthy eating patterns such as consuming 3 meals a day with planned snacks each day. Children and adolescents should be encouraged to not eat while watching television or while using computers. Using smaller plates should also be encouraged when eating to make portions appear larger. The American Academy of Pediatrics identifies that common dietary recommendations to help reduce caloric intake and promote weight loss in children include eating regular meals with planned snacks, reducing portion sizes, choosing calorie-free beverages with the exception of milk, to limit juice to 1 cup per day, to increase consumption of fruits and vegetables, to consume 3 or 4 low-fat dairy products per day, to limit intake of high-fat foods, to limit size and frequency of snacks, and to reduce calories consumed from fast food meals. Physical activity is a large component of weight management and for the prevention and treatment of type 2 diabetes. The American Academy of Pediatrics suggests that clinicians should encourage children and adolescents with type 2 diabetes to engage in moderate to vigorous exercise for at least 60 minutes daily for the reduction of BMI and improved glycemic control in patients with type 2 diabetes. The American Academy of Pediatrics defines moderate to vigorous exercise as exercise that makes the individual breathe hard and perspire and that raises his or her heart rate. The American Academy of Pediatrics identifies an easy way to define exercise intensity using the talk test. During moderate exercise, a person can talk but not sing. During vigorous exercise, a person cannot talk without pausing to catch a breath. Adherence to an exercise regimen may be improved if clinicians provide the patient with a written prescription to engage in physical activity. It is most helpful if the clinician recommends an individualized approach that can be incorporated into the child or adolescent's daily routine and is also tailored to the patient's capabilities and preferences and recognizes the family's circumstances. Together with the patient and the patient's family, the clinician should help determine an individualized plan that includes specific goals to help reduce sedentary behavior and increase physical activity. Patients should be encouraged to identify a wide variety of physical activity that can be performed both easily and frequently. Patients should be encouraged to perform physical activity that may be gained through structured games and sports or activities such as walking. Non-academic screen time should be encouraged to be restricted to less than 2 hours per day. Clinicians should just encourage patients to not use video games, and the use of television sets in children's bedrooms should be discouraged. Oh my gosh.
When diet and exercise don't work to manage blood sugar levels, diabetic medications or insulin therapy is needed. Deciding on which treatments to use depends on the person's blood sugar levels, other associated health problems, and weighing the pros and cons to each medication, such as the cost of the drugs. A combination of different drugs may be used to help control blood sugar in different ways. Testing blood glucose levels. A person will choose the monitor that best works for them. The process is simple. First, the person washes their hands, and then they prick their finger with a lancet, place a drop of blood onto the blood testing strip in the sugar meter, and then the results will be given within a few seconds. Testing may be needed when a person is newly diagnosed with type 2 diabetes because sugar levels may be unpredictable and harder to control. If there are symptoms associated with an abnormal blood glucose level, the person will need to test their blood sugar with their personal blood sugar monitor. Signs of trouble include hyperglycemia, or hot and dry, sugar high. Eating too much is the cause of hyperglycemia, along with being ill or not taking enough glucose-lowering medications. Hypoglycemia, or cool and clammy, need some candy, means that the blood sugar drops below the target range. This could be because the person skipped a meal or sustained extra physical activity. Some medications include metformin, which is also known as glucophage. This helps to improve the body's tissue sensitivity to insulin and decreases glucose production by the liver. Along with this medication, the person still needs to make some lifestyle changes, which includes losing weight and exercising. Alternatives to metformin include Januvia, Prandin, and Starlix. If metformin is not enough, other oral or injectable medications can be added. Examples of these drugs include glucotrol, diabeta, or Amaryl, which stimulate the pancreas to produce and release more insulin. Precose, or acarbose, is another drug that blocks the action of the enzymes that break down carbohydrates in the intestines. Low-dose aspirin therapy may also be prescribed in special cases, along with antihypertensives and cholesterol-lowering medications in order to prevent heart and blood vessel diseases. Insulin therapy may be needed because normal digestion interferes with insulin taken by mouth. Insulin must be then injected. Injections are done with an insulin pen using a very fine subcutaneous needle. Types of insulin include fast-acting, long-acting, and intermediate. Common brand names include Humalog, Novolog, and Lantus. A mixture of different types of insulin may be prescribed to use throughout the day and night. Long-term monitoring is done through the hemoglobin A1C blood test that gives the physician an overall picture of blood sugar control over the past 3 months. The target result is 7, and anything above may signal that a current treatment plan is not as effective as it should be. This blood test should be done at least twice a year at a minimum, and it is not used to replace daily glucose testing. Based upon results and compliance, current treatment may be changed to help manage blood sugars better. And here are our references.